Okay, maybe we'll get started now. I think we have a good attendance now. Some people may also still be joining. So thank you, first of all, to the organizing committee for inviting us to moderate this session. My name is Jeff Watson. I'm a medical oncologist at Mount Sinai Hospital and assistant professor of medicine at the University of Toronto. Alongside me are my co-moderators, Dr. Yolanda Augustin from the Royal Marsden Hospital in London, England, and Ms. Sudha Yalamanchili from MD Anderson in the US. By way of introduction, Dr. Augustin is a medical oncologist with a special interest in sarcoma and global oncology. She completed her undergraduate medical and palliative care training at Guy's, King's, and St. Thomas School of Medicine before undertaking clinical oncology training at the Royal Marsden Hospital in London. Upon completion, she undertook a research fellowship within the Royal Marsden Sarcoma Unit and obtained higher training in clinical trial design and delivery for novel systemic anti-cancer therapies and radiotherapy. She's also working with oncology colleagues in Malaysia on sarcoma service development, research, and training, and is developing a prospective database for Malaysia. Ms. Yalamanchili is a nurse practitioner in the Sarcoma Medical Oncology Unit at MD Anderson Cancer Center. She works in clinical practice with Dr. Ravi, which specializes in vascular tumors with a particular focus on angiosarcoma and EHE, or epithelioid hemangioendothelioma. She serves as the APRN representative for the new patient team to help streamline incoming patients. She's also involved with managing logistics for cardiac sarcoma patients to ensure delivery of multidisciplinary care and support services. We're also thrilled today to be joined by Mr. David McDonald. Mr. McDonald was diagnosed with cardiac sarcoma in 2019 and received his treatment at MD Anderson Cancer Center, and he has kindly agreed to share his story with us today. So welcome, David.
Thank you, Jeff.
I guess just along, if there's any questions or comments over the course of this session, please feel free to enter them into the chat box. We will be closely monitoring this. So we'll start off with an introduction with Dr. Augustin, just to briefly describe the current landscape in the treatment of cardiac sarcomas. And then Ms. Yalamanchili will discuss briefly the referral process, patient services provided. And then we'll ask David to talk about his own experience. So Dr. Augustin, yeah, over to you.
Thank you so much. So just to mention that the presentation today is actually tailored for patients. And I'm briefly going to be sharing our experience of managing cardiac sarcoma at the Royal Marsden. Do you have the slides, Jeff?
Yeah, one second. Sorry, I'm having issues here. Can you see that?
Yes, thank you. So next slide, please. Cardiac sarcomas are a rare sarcoma type, and surgery, complete resection if feasible, is actually the main management and treatment for localized disease. And in the UK, we use sequential chemotherapy and radiotherapy often as part of the treatment for optimal local control. And here I would stress that management at a specialist sarcoma center is recommended, but it can sometimes be difficult, particularly in the UK context, as patients may be very unwell and require emergency surgery. So Jeff and Sudha, could you maybe just also go through the pathways at your centers in Canada and the US briefly?
Yes, in the United States, cardiac sarcoma patients, we typically like to do neoadjuvant chemotherapy, if possible, if the patients are hemodynamically stable, and then we like to do surgery afterwards. And for patients that are not surgical candidates, we have been starting to use radiotherapy as a treatment after chemotherapy.
Thank you.
Yeah, I agree with Sudha. In Toronto here, certainly we also use neoadjuvant chemotherapy, particular combination doxifos, and this was based on this study by Dr. Abu Saleh and colleagues at in Houston, Texas, as we discussed earlier today as well. And we saw the importance of R0 resection on outcomes. That's when there's no residual tumor post-operatively. The role of post-op radiation, it can be considered, for example, in positive margins, but I think all cases warrant discussion, certainly at a tertiary care center specializing in cardiac sarcomas and with regards to the sequencing of treatments.
Thank you. Next slide. So this just summarizes our experience at the Royal Marsden over a 25-year period. And this was a retrospective case notes review where we included 68 patients with a median age of 46 years between 1987 and 2021. About a third of patients, 21 patients, actually had radical radiotherapy as part of their treatment pathway. And here in the slide, we just list the number of patients who had trimodality treatment with surgery followed by sequential chemotherapy and radiotherapy, which was about 20%. And some patients also had surgery followed by radiotherapy. And in a small proportion, patients had chemotherapy followed by definitive radiotherapy where they were not considered to be suitable candidates for surgery. The most common chemotherapy regime was doublet doxorubicin and ifosfamide for 6 cycles. In general, the radiotherapy experience that we've had at the Marsden is that radiotherapy is actually well tolerated, and all patients within this cohort completed radiotherapy on schedule. And I just listed there some of the acute latent side effects, which I think we won't go into detail, but just to say that it was well tolerated. Looking at survival outcomes, in our cohort, patients who had radical radiotherapy had good local progression-free survival at 1 year of 85%, and the overall survival at 1 year was 90%. And patients also had prolonged median survival of 34 and 46 months, and in the combination group of surgery, chemotherapy, and radiotherapy versus surgery and radiotherapy. This is just a management algorithm that explains how we work patients up when they're considered potential radical radiotherapy candidates. They have a staging CT chest, abdo-pelvis, and MRI head, as well as a CT PET if there's any uncertainty regards distant metastasis. And patients also have a baseline echo. And at radiotherapy planning, we use 4D CT scans and a cardiac MRI to delineate the postoperative tumor bed to aid planning. And patients are seen weekly on review during radiotherapy so that any symptoms can be managed proactively. In terms of follow-up, patients then go on to have a cardiac MRI and staging CT chest, abdo-pelvis every 3 months for the first 2 years, and then 6 monthly at year 3 to 5 and annually at year 5 to 10. Management is taken as part of a multidisciplinary team approach, which includes cardiologists, cardiothoracic surgeons, radiation oncologists, and medical oncologists. So in summary, radiotherapy can be delivered safely and effectively, and a multidisciplinary approach is really important. And apart from the medical team that I mentioned, specialist nurses, physiotherapists, and psychologists are also critical to managing this disease. Thank you.
Thanks so much, Yolanda. So Sudha, I'll pass over to you.
Okay, great. I'll share my screen. My name is Sudha, and I'm a nurse practitioner at MD Anderson Cancer Center. Thank you so much for this opportunity today to speak with you all at this conference. I'm going to share with you the new patient experience for patients with cardiac sarcomas. The first step of the process is to make an appointment, and please make an appointment with a high volume cancer center by calling the new patient office or request an appointment online. Physician referrals also go through the same process and the same portal. Listed here is just MD Anderson information, just for reference purposes. You can also use Google to find a high volume cancer center close to you. Most high volume centers are extremely busy. So if the turnaround time to create an appointment is greater than 1 to 2 weeks, please have your local doctor reach out to the sarcoma specialist directly. At MD Anderson, we actually have a group of individuals called the Sarcoma Patient Access Representative Group who work hand in hand with patients, and they help obtain outside medical records, tissue if a biopsy is completed. If no biopsy is established, we refer our patients to Dr. Reardon at Methodist Hospital to obtain tissue diagnosis. They also help obtain outside imaging and financially clear the patient prior to the first visit. We also see a number of international patients outside of the United States, so we do coordinate with the International Center to achieve this. On the day of the first visit, new patients will first meet with the registration team who obtain consent for treatment and utilization of patient data for research. Afterwards, the patient will meet with the clinical care team, which includes the nurse practitioner, or PA, as well as the physician. The physician basically focuses on reviewing patient goals and providing a treatment plan for the patient. They also discuss prognosis as well as advanced care planning. If the patient is advised to start on chemotherapy, we do provide chemotherapy handouts and booklets to help them prepare for this. After the visit, if the patient needs any kind of social support services or housing needs, a social worker is on site to help address these issues. Beyond physicians and nurses, there's a larger support team to provide holistic care for patients. These services include a registered dietitian, social worker, and case manager. They help with housing and home supplies such as oxygen, wheelchair. Pharmacy staff is super helpful with providing recommendations on treatment planning. PT and occupational therapy services are also helpful, especially for patients that are hospitalized or straight after surgery. Integrated medicine focuses on holistic care. Sarcoma genetics, patient advocacy, and language services for non-English speaking patients are also helpful. We at MD Anderson help patients or encourage patients to use MyChart, which allows them to connect directly through an online portal to their clinical team. And some other services that are helpful for cardiac sarcoma patients include a cardiac tumor conference, which is held once a month, and it's a global effort to discuss and plan treatment for patients who are actively on therapy. In addition, in patients with advanced disease, we perform molecular profiling to understand the key vulnerabilities that have therapeutic significance. Our precision oncology decision support team also provides therapy recommendations based on molecular features of the tumor. And our Institute for Personalized Cancer Therapy provides recommendations for novel agents through clinical trials. Thank you so much.
Thanks so much, Sudha. So I'll turn to David now. David, thanks again for joining us today. So I guess we would all like to start at the beginning, ask about your initial symptoms and going through your story. When did you first realize that something wasn't right?
Okay. Thanks again for having me today, Jeff. I appreciate it. It's good to be here with you and to be with the other people that are here. Just so you kind of know a little bit about my history, I'm currently 51 years old. In 2019, when I was diagnosed, I was 47. As far as health goes, I was in pretty good health to start with. I'm a college athlete. I played soccer in college. I work out 6 days a week. I run, do fitness, and do lifting and those kinds of things. And so when I'm just not typically very sick. And so one day I was standing up and I experienced that sensation like you have when you stand up too quickly. You get that initial dizziness that hits you. And so I just kind of held onto the counter and I thought it would just pass. And so I stood there for a minute and 2 and 3, and it didn't get any better. So I was like, well, maybe I need to sit down. So I sat down, and then I was like, well, maybe I need to lay down. So I laid down. And what I found was that, just the symptoms really just weren't passing. I started to feel sweaty. I started to feel clammy. And so eventually that feeling kind of passed over. I still felt dizzy, but I didn't feel the kind of the weight of the way that felt. And so I had to call my wife and ask her to come pick me up. And so from where I was, I didn't feel like I could drive. So she came and picked me up, and she's like, well, what do you want me to do? And I said, well, I guess you probably should take me to the hospital to make sure that everything's okay with the dizziness that I was experiencing. Because like I said, I still just didn't feel right. So she took me to our local hospital, Mansfield Methodist. And so there's a cardiac center that's there. But when they did my initial workup, they were concerned that maybe I would had a stroke. And so they were all focused on the stuff with my brain. So they did my CT scans. They had me talk with some stroke specialists to be able to make sure I could touch my nose and whether I was having tingling and those kinds of things. And so I wasn't having any of those types of symptoms. And so they really didn't know. And so they wanted to keep me overnight. They thought maybe it was like a deep inner ear infection that needed to be treated. They weren't really sure about what it was or how it was that those things were going to transpire. So they decided to, like I said, to keep me and try to treat that. And so after that initial kind of workup, they thought that I just needed to go back and see my primary care. They really didn't feel like there was anything else that they could really do for me in the moment. Since everything else kind of came back negative. They did tell me that they'd asked me, said, do you know that you're anemic? And I just had my physical 2 months prior, because this was March of 2019. And I was like, I just had my physical in January and everything was fine. Nothing came back in my blood work. And they said, well, your iron levels are low, so you need to go talk to your primary care and see what's going on. So they thought maybe, again, something like prostate cancer or something like that was kind of pulling that blood away, or something that could have been going on. So they released me. I go see my primary care within the next couple of days. They start to say, we'll start with some iron supplements and those types of things. And so just kind of say, we're going to monitor you and we'll kind of see how it goes. They were concerned that maybe we need to do a colonoscopy. And so those kind of things down the road that they wanted to kind of situate. So eventually I just kind of, go about my life. I did feel tired. And so as a result of that, I just kind of didn't work out for a couple of weeks. And so it had been about 2 weeks, is the middle of March when that happened. And so by the end of March, very beginning of April, I decided to tell my wife, said, well, I'm just going to go for a jog just to see how I feel. She's like, well, what if something happens? Like, I'll be fine. I'm not going to go that far. So I just wanted to see how my body could tolerate, because I just hadn't done anything. So I took off jogging. I mean, I wasn't sprinting. I just took off jogging, and I probably had made it 20 yards, and I felt like my heart was going to beat out of my chest. And so I felt short of breath. I started to feel dizzy again. And so I just kind of walked it off. And so I just walked, and then eventually I calmed down. And so then I would jog again, and it would start again, and then I'd walk again, and I'd jog. And so I did that for about a mile lap to get back to my house. And so I told my wife, I said, this anemia thing is real. Whatever's going on. I said, I feel so tired and feel messed up. And so the next day I went off to work, and for the first time really since the initial time it happened, I was walking and I felt dizzy again. And so that dizziness hit me. I sat down, it kind of passed. But by that evening, I was not feeling well. I was coughing. I was having a hard time breathing. And so the next morning, after not sleeping literally all night long, my wife got up and said, well, what do you want to do? And I said, well, maybe you could take me back to the hospital. So we go back to the hospital. It's 2.5, 3 weeks after the initial time I'd been in there. And so, so I said, I'm having these problems, I'm coughing, this kind of thing. And so this time now, because they didn't the first time. So this time now they do a scan of my chest. So everything had been concentrated in my brain, looking into this stuff. And so this time they did a CT scan of my chest. And so they came back and said, well, the coughing and stuff, they said, you have pneumonia in both of your lungs. I'd never even had pneumonia before. They said, you have pneumonia in both your lungs. They said, you probably got it here at the hospital when you were here last time. So they had that, but they said, you have pneumonia in both your lungs. And they said, there's a huge tumor inside your heart. And so I was like, I didn't even know how to respond to that. We were just like, okay. So from that situation, they're like, we need to do some tests. We need to do some additional scans, and we need to deal with it. So they did an echo, so I could see it. They sat and showed me on the screen, and they're like, here's why you were getting dizzy. The tumor was inside my left atrium, and so they assumed that it was going to be an atrial myxoma. I mean, based on location and statistical likelihood, they thought it's an atrial myxoma. So we needed to do a resection. We needed to get it out. And so you could see it when my heart was beating. You could see that tumor because it was big, and that would just flop inside that left atrium. And what had happened was it was blocking my heart and stopping that blood from flowing. And that's when I would get dizzy. And then eventually my heart would kick it out again, and then everything would be fine. So that's why I wasn't having like constant symptoms. So they're like, we're going to need to do surgery. And so we're going to need to take care of the pneumonia first, and then we can do the procedure. So I was in the hospital for a while. My surgery, and the scans that they did several different makeups and MRIs that they did, and CT scans. They did a scope down my esophagus so they could put a camera in there and see behind, to be able to try to make sure they knew where everything was and have the best images they could going into that before they did the surgery. So all that stuff got put together. And then initially on April 15th of 2019 is when they did that initial surgery.
Thank you, David. I think that's really so eloquently explained. But maybe can you also give us a little bit more information about how it felt in the post-operative period and in terms of your recovery? And then also what happened next when you went back to see the cardiac surgeon to actually get the histopathological results?
Okay. So the surgery itself, like I said, the surgery was on April 15th. I was discharged by April 19th. So I was only in the hospital for a few days post-surgery. It was extremely painful. I do not recommend open heart surgery. And so after that first day, after my surgery, the very next day, they had me up out of the bed. They made me have to get up and walk around. And so when you feel like you would think they would just let you stay in bed and rest, but they're like, no, you need to get up. We need to get you moving around. We need to make sure that your heart is working properly. We need to get all this stuff functioning again. And so it was kind of rough because being in the cardiac ICU unit there at the hospital, like I said, I was by far the youngest person that was there. I'm walking by other people's rooms and they're like in their 80s and their 90s. I'm like, I feel so bad for you people because I'm 47 and I'm dying right now. I can't imagine what that would have been like to try to go through that physical recovery. But after a few days of going through there and that stuff initially, they got close to discharge. When they put me back together, there's a difference between my first surgery and my second. My first cardiac surgery, they used a plating system in my chest. There were titanium plates that they used to fashion my sternum back together that were really secure. My surgeon locally here in Texas where I was, Dr. Bradford, said they switched over to that plating system about 5 years ago at that time because the recovery time they found was cut way shorter for people in recovering from open heart surgery. So I felt secure in the way that my chest felt. And so when they released me, I didn't feel like I was going to blow open or anything like that I felt like I was really strong and secure. And so initially, I get up after they released me from the hospital. They wanted me to still be as active as I could to make sure I'm getting up and I'm walking. I'm not just sleeping all day. And so fitness is important to me. So I wanted to make sure again that I could try to be as active and get back to things as quickly as I could. They say it was going to be an 8-week recovery. They didn't want me picking anything up like more than 10 pounds for the first 8 weeks. After 6 weeks, I could drive. So for 6 weeks, I couldn't drive. They're like, the last thing you want is to be driving a car and have an airbag go off in your chest. So that would not have been a pleasant experience. So they preferred me just to not drive around if I didn't have to. So staying here at home, just recovering, just being able to focus on my health. Everything was going well. I did my follow-up with my doctor 6 weeks out because that was the first day that I could drive by myself. My wife went to work that day. She's like, you need me to stay home and take you? I was like, no, I'll be fine. I can drive myself. So drove for myself down to the doctor for the first time and saw my cardiac surgeon. And so he goes through and said, everything's healing well. Everything looks good. I've got an 11-inch scar on my chest that they had glued back together, a couple of drain holes that they had from being able to make sure that all the fluid is out of my chest cavity. And so we sat down and had the discussion about, how I was feeling and post-recovery. I'm like, when can I start lifting again? When is it okay to do this? And he was, kind of giving me those parameters about what was acceptable, what was okay, and what I felt comfortable with. And I was almost done with the appointment, felt like I was about to walk out. And I was like, oh yeah, what came back from the biopsy of the tumor? And I was like, was it an atrial myxoma? And he's like, no, it was sarcoma. And of course, I've never heard, I had no idea what a sarcoma was. And he was kind of just very flippant about it, but he was like, no, it was a sarcoma. And I'm like, oh, okay. And he's like, I'm going to need to refer you to an oncologist. They're going to need to follow up with you. And I'm like, okay. And so I was just kind of like, oh, right then. And so we're kind of walking out. They'll be calling you. I'll have the doctor get in touch with you to make an appointment. And I was like, could you tell me again what it is that I have? And so he like wrote it down on a Post-it note and stuck it on my folders, like sarcoma. So I was like, okay, I just need to make sure I know what I'm dealing with. And really just kind of went home, and that was really the end of that discussion. I don't know if he just didn't have a lot of experience with that and dealing with those kinds of cardiac tumors. Like I said, it was fine. He had done surgeries like with dealing with atrial myxomas and those kind of things. So I was confident through the surgical procedure with everything, but I just don't know that, they kind of knew what to do with me. So he referred me off to my local oncologist. And so Texas Oncology, Dr. Diggy Card there is the one that saw me. And so when I show up for that initial visit, that was kind of my first experience of kind of going through those things to kind of get some information what was going on. So when I go to my oncologist, I show up for the appointment and they give me a piece of paper when I check in for me to give to the nurse. It's like the little medical history form. And so I go through, and a lot of it's pre-filled out. Like one of the things that's on there, hey, Dr. Ravi, one of the things that's on there is I listed like 30 different cancers. And so, and like it was pre-coded. So I look down all the list of all these cancers, and at the bottom in the right corner, it says other, and mine is checked other, and they've written in their sarcoma. I was like, so I'm not even like in the top 30 of cancers. I mean, so they just had to like write mine in is what's wrong with me. They don't. So these people either never see anybody like me, or they just have too many things that they can list. So they just try to hit the most popular ones. So when I go back and see the oncologist, he's like, he goes, so as I'm sitting there, so after I see that, I really hadn't done that yet. So I kind of get my phone out, and I'm like finally like, okay, well, what is sarcoma? So I like look up sarcoma, then I'm like sarcoma in the heart. And so I'm kind of like, oh, I'm going to die. The report I'm seeing here medically is like, most of the time it's found post-mortem. The average person lives 6 to 9 months after discovery. I'm like, oh, okay. So I go back to see the oncologist, and I'm like, so how is this going to go? And so he's like, what you have is extremely rare. He goes, he goes, I could go through my entire career and maybe see 1 or 2 of you that would come through here again. He goes, I can treat you. He goes, this is what I would do. But he goes, I really encourage you. He said, if you were my brother, if you were my dad, I would tell you that you need to go to a sarcoma center. You need to go someplace that treats this stuff. He goes, I can do it. But he goes, I really, really would encourage you to be able to go to a sarcoma center. He said, I would tell you to go to MD Anderson. He goes, we have one at UT Southwestern in Dallas. But he said, I would go down to MD Anderson if I were you. So we talked for a little bit. He kind of told me what was going on and what the kind of prognosis of things were. And then I went straight home and made a phone call down to MD Anderson. And so they took my information from me that afternoon. They said, we'll refer this to the sarcoma team, and then we'll send information to you relatively quickly. So they were extremely nice. I mean, for as many people as they probably have them calling a day, the process of being able to talk through that, I felt very comfortable with by the time that I was all said and done. So I was very happy with the way that all kind of went. And so within a week or two, it was pretty fast. Within a week or so, I was down there seeing Dr. Ravi at MD Anderson.
Yeah, thank you. And you said that when you went there, they rescanned you, and unfortunately the tumor had regrown. So you actually had to have chemotherapy followed by a second surgery. But maybe could you just talk us through your chemotherapy preparation and the chemo sessions that you had, which were the patient education sessions?
Okay. So yeah, by the time I got down there, I was about 8 weeks post-op at that point. So I go down there, and Dr. Ravi gets new scans of my chest and everything. And they're like, well, as much as zero margin as they'd gotten in your heart, said the entire tumor, I mean, it's grown back. It's there again. So like, we need to start chemotherapy immediately. So the scans were quick from when that initial appointment that we had. The chemotherapy started within a week of that. I mean, it was very, very quick. I didn't have much time to go back home because I live 3.5 hours from Houston, to drive back home, get some stuff together, and come back down to start that, because they wanted me to do it locally. Dr. Ravi told me that the way that they wanted to administer it was a little bit different maybe than some people get their treatments. So I had to go through a chemotherapy class, which was in person at the time, post-COVID. I'm not sure kind of what they do now. Suda said that they can do a lot of that stuff virtually now. But I was in a class, like with a nurse that was leading it that talked through. They gave me a big manual about how to deal with chemo, side effects, diet, nutrition, exercise, a lot of really good information that was very helpful to me that I used all through my chemo process. And so the chemos that they started me with, they put a PICC line in my right arm because they wanted to be able to dump the chemo right into my heart. So that PICC line that ran up through the artery and then right up into the valve of my heart, where they could administer that way. And so the doxorubicin, they were going to initially put in like in very heavy doses on those first days. I remember the first day I had to do it was on a Saturday. And so they had not done like my patient clearance type things like safety protocols. And so they had to call Dr. Ravi like on a Saturday afternoon or Saturday morning and say, hey, we need to go through this real quick. And so he told me the same thing that he had told me when we had our initial consult. He's like, I just need to remind you that us administering this such a large dose on this first day, he goes, it could put you into cardiac arrest. So I just want you to know that is a possibility. So I'm like, I'm in a hospital. I'm okay. I think I'll live. It'll be all right. So that initial day, I had a 6-day cycle that I did. So that first day they put it in all the doxorubicin, and then the other days I went through the ifosfamide. So it was about 5 or 6 hours, I think, initially that those timeframes were that it would take to administer through those things. And so I initially did my first 2 cycles at MD Anderson on an outpatient basis. So they would see me during the day, I'd do the thing, and then I would go back. I had some friends that lived in Houston, and so I was able to stay with them. My wife and I stayed with them. And so in the evenings we go, and I'd go for a walk with my little Mesna bag because I had to have a Mesna pump that allowed to be able to keep those chemicals moving in me during the nighttime, during the day. And so I had to do, I was on there for 6 days, and then I was off for 2 weeks and then back on for another week. And so I did those initially. I'm a teacher. And so I was doing that during the summertime. It just kind of worked out that way. And so I did my first 2 cycles at MD Anderson, and then they worked it out where I could start doing my stuff locally back home. Unfortunately, whenever I was doing it at home, though, the oncology center at the hospital that I use locally, they don't, the way that their office hours work or whatever, with them being able to administer the medicines I would need, they would have to do me inpatient. So I had to go into the hospital for those 6 days initially to be able to have those treatments. And so it was, the outpatient basis was nice, but it was in Houston. To do it at home, I had to just go sit in the hospital for 6 days. And so I had to learn how to pass that time for the non-treatment hours of sitting up there. It really was like I was checking into a hospital, because they would call me when the bed was available. I'd grab my suitcase, I would go up to the hospital and kind of check into my room and just hang out for the week. So when they weren't administering stuff, and even during the day, I would just get up and just walk around through the floor of the hospital while I was doing my treatment with everything stuck in my arm to try to make sure I could just stay up and just stay active. It just in my brain, it just didn't sit with me, just sit well, just to be able to sit there and just take all these chemicals in and not have any way to kind of discharge that stuff. So it was important for me to be able to make sure I stayed active and still got up and walked around and did things during the day so that I could kind of work through. So eventually the tumor got small enough. By the time we get to November of 2019, I'd gone through several cycles then of chemo at that point. And so the tumor had gotten small enough that they wanted to do another resection. So Dr. Reardon at Houston Methodist did my second open heart surgery. So same procedure again, cut along the dotted line that was already there, opened me up. This time, instead of just scraping out the tumor from the inside, he removed the entire left atrial wall of my heart and then rebuilt it. So he's like, anything the tumor has touched or been around, I'm just going to take it all out. And so I'm just going to remove it all. So he rebuilt it, put it back together, put it back in me. He used a different plating system. And that's why I mentioned it the first time. He just used the standard sternal kind of wire clamps. And so had my choice, if I was picking between how to do my open heart surgeries, the plating system that was for my initial surgery was way better. The sternal clamps move. So like even doing things like brushing my teeth would cause my chest to move. And it's not like it hurt, it's just uncomfortable. And so that plating system held me in place. There was none of that movement that happened secondary, where with Dr. Reardon, after that surgery, he told me, because it's really going to probably be about a year until you're really comfortable like doing things with heavy weight again. Just kind of take it easy as you go along. And so that recovery period was harder the second time around from that surgery than it was compared to the first. And so after that, that's when, after my second open heart surgery, I had the same surgery 7 months apart. So after the second time, that's when we decided to start doing a cleanup chemo and change the routine that I did in order to try to make sure there was nothing else floating around.
Thank you so much, David, for sharing that with us. I know you got gemcitabine and docetaxel the second time and adriamycin and ifosfamide the first time you received chemotherapy. What were the major side effects to these so patients can kind of understand what you went through, and how did it impact your quality of life, your job and home life as well?
Well, the initial chemos that I did, the first rounds that I did, nausea was always the thing they said was going to be the biggest side effect. They said, obviously, you're probably going to lose your hair, which I did, and it never really grew back, but I have some. But I'd rather be, like I said, I'd rather be bald and alive than hairy and dead. So, so through the initial treatments, the nausea really wasn't that bad. The very first treatment, the very first day, that evening, I felt sick. And so I learned very quickly to stay ahead of that, to not wait till I felt bad in order to start taking my medicines. So the pharmacy would give me stuff to take. And so after that first day, I was like, stay on the schedule. And so whether I thought I needed them or not, I went on ahead and took those medications to make sure that I stayed ahead of that. So for me, the nausea aspect of that was never a big deal. I felt kind of tired as I went through those cycles, especially as over time, as the chemicals were kind of building up in my body cycle after cycle, I would start to feel a little more tired as time went on. But I tried to make sure again that I stayed active during that time. And so I did have to be mindful of what I ate. And so it wasn't necessarily that I felt nauseous, but I sure was kind of preferred certain things that I wanted to stay away from or didn't feel like eating, and certain things that I did. So I just made sure that whatever it is that I felt like eating on that particular day, that I just had access to it so that I could. So whether it was getting smoothies from Smoothie King or whatever it might have been, that I just feel like it would set well with me. And so from that aspect, with the first treatments wasn't bad. I did have some mouth sores that came up, or that would try to. And so I had the care of faith that I would wash my mouth out with every day to make sure that I didn't have any of those sores that popped up. And again, learning to manage that too. So initially, like I said, in hindsight, it never really seemed like it was that bad. I know there were days that I felt really, really tired, and then I felt just really pressed on through that process. But after that initial wave of chemo, the second round, the stuff that I did for chemo was actually for me physically worse, because the fatigue that I got from that really was bad. I felt during those cycles of those days, I felt really, really tired. And so again, it would dissipate and it would feel better as time went on. But I really did feel I had to kind of push through. And so that's why, again, I tried to make sure that I got up and walked and did those kind of things. And so after even through my initial chemo, like I still worked. I was off during that summer again because I'm a teacher, but when school started that September, I would go into the hospital for a week and then come back and teach for 2 weeks. And I go back to the hospital for a week and come back and teach for 2 weeks. So it didn't really keep me from doing anything. Like I said, those initial days, it kind of worked out always that I'd have a day or two before I'd have to go back to work. They always ended my cycles like on a Friday. So I'd have the weekend to recover before I go back to school on Monday. So from that aspect, it was always kind of scheduled well so that it made it easier for me to transition. So I always had that time to recover before I had to go back in. And then after my cleanup chemo, I did several rounds of that. And again, and did that locally. I did a round or two at MD Anderson, and then they released me to do that at home locally as well, that I was able to kind of work my way through and continue to work and do those kind of things until March of 2020, which is when COVID hit. And so I had about a cycle or two left, but Dr. Ravi, I'd met with him at the beginning of March, right when all that was happening. He's like, well, we probably need to stop doing any non-essential chemo on you because of the COVID stuff. And so we'll just see how things go from there. And so since then, I've not had a reoccurrence in my chest. After my 2 resections, after the two separate bids of chemo that I've never had a reoccurrence in my body or my chest anywhere. Just as a reference, I've had a secondary tumor that popped up in my brain in November of 2020. That came around that I had to have a resection done on and some radiosurgery on it. And then the most recent one, I had a small one that popped up right next to the tumor bed that I had in March of 2021, or 2022, sorry, but 2022 that we just went through. That was just about 10 months ago now. So that, for like I said, for the treatment wise, I know everybody kind of deals with those things differently as far as how they feel from those side effects, and mentally it kind of affects people differently. For me, from a support perspective, I had a lot of people around me, you know, that were helping and supporting me through that time, that were, you know, mentally just trying to kind of keep me moving forward. And I kind of felt like it'd be disingenuous if I didn't say, you know, that again, that my faith and God is very important to me. And so I had a lot of people praying for me. I spent a lot of time in prayer, just kind of staying focused and know that I wasn't doing this under my own power. And so with the support group that I had around me and the people that I had encouraging me, I felt like that there was always a light at the end of the tunnel. I've told Dr. Ravi Asuda before, I've never felt any, from diagnosis to surgery, anything that's happened, I've never felt that there's anything they've told me that I felt like I was gonna die through this process. There's always been a solution to be able to help me and to be able to go to that next step. And they always knew the next thing that we needed to be able to do. So I've never felt lost or adrift. And then we're like, well, I don't know what to do with you now. You know, they've always been able to have a solution to kind of where that next step needed to be.
David, just a couple of questions. You said after the gem tax, the pandemic hit, obviously, but I wanted to ask how frequent were your follow-up visits in clinic and then your scans as well?
Okay. The furthest my scans have ever been apart are 3 months. I've still never been further apart than that. When there've been anything actively that they've been treating, they've usually been every 6 weeks that I come and do my scans. And so I drive to Houston to do those. I don't do those locally. I drive down to Houston to let MD Anderson do those scans whenever those things come up. And so like right now, I'm just now back on a 3-month cycle. And so of my chest and my abdomen and my pelvis, and then the same thing with doing my brain scans on the same cycle. So during those treatment times, typically every 6 weeks that they're seeing me, again, between really kind of falling between those treatments. So I kind of would go like through 2 cycles of chemo or 2 cycles of cleanup, and then I'd come back and be able to and have scans again. And so there've always been frequently be able to look at those images to make sure that everything was clean and that everything was good. So I'm just coming off brain scans that were being done every 6 weeks. And so now with the one that I just had in December, that they've just released me now with radio oncology to not have to do that again until another 3 months down the road now.
And then a couple of other questions. You touched on some of the supports and support groups that you came across. You know, if you were speaking to patients now, what are some of those groups that you may recommend as a good resource?
Okay, yeah. Because if you just start looking up stuff online, you're going to find all kinds of crazy stuff. Like I said, that first day for me, that was like kind of eye-opening. And so, but there are Facebook groups out there. There are organizations. There's the Sarcoma Awareness of America. You know, there's several different groups that are out there. There are Facebook groups out there. And so really early on, I found those Facebook groups because I was just kind of curious for my own condition. You know, I got on there that first day when I found it and I was like, here's what's going on with me. Is there anybody else out there that's gone through this stuff? Here's the chemo that I'm doing. What's happening? So there were people out there, and every single day I can see people in those groups, you know, that come up in my feed, that I can see those people and individuals that just want answers, that just need help. And so there's a lot of resources that are out there in that regard within social media, with some of these organizations that are there to kind of help and give information outside of Wikipedia or WebMD, that you can try to get some people that can give you some information to kind of and see what other people's perspectives are. You hear some very sad stories. You hear some very encouraging stories from some of the stuff that people have gone through. Because I know for me, as bad as what I have is, there are people that I was sharing earlier with Suda and Yolanda that, you know, I have friends that have already lost their battle with cancer, that were diagnosed after me, that haven't made it as long as I have, that you would say that wasn't necessarily as severe as a case, and maybe as what that I'm dealing with, just because of where it is. But you know, that support, you know, is there. I learned very quickly to not try to operate as an island. You know, I've always been a very self-sufficient person and feel like I could take care of my business and I don't need, it's okay. I can take care of it. It's all right. But what I really learned through my cancer journey is that it is okay to take people's help. You know, initially when I was having to drive down to Houston for those visits, you know, like I said, I had friends that lived in Houston that my wife and I stayed with them while we would come in to do our treatments. After they had moved away, I had friends that would donate hotel points so that we could stay in hotels. You know, they had their award points that they would just book rooms for us to be able to stay in. So I've learned to accept that help from people. I know for a lot of people, they're just like, you know, I'm okay. I'm okay. I can take care of this. But it's helped me connect with my friends a lot. It's helped me to know that I've got people out there that are supporting me, that are praying for me. I know that they want updates because my friends will start texting me and go, hey, you haven't posted anything in a while. Are you okay? Is everything all right? Because they're afraid if I don't say anything that everything's going bad. So it's good to know that that I'm not here by myself. And like I said, the medical team that I have through MD Anderson has been fantastic. It's great for me because I have the group at MD Anderson, but I have my local oncologist too. I mentioned that when I was talking with you, Jeff, the other day, that I know that there's people watching from both sides. So I know that there's nothing. I feel like there's nothing that's going to kind of slip by them because I've got the team at MD Anderson that's monitoring my scans, that's doing those things. I've got my local oncologist that's following up, that follows those things in my chart, that does my local stuff that I'm doing here. And so I know that I've got a lot of people around me that are helping through that process to make sure that I'm being cared for and being looked after. And I feel it. Thanks, guys.
And then one last question for me, as one sports aficionado to another. I see the football behind you, the Buffalo Bills helmet. What has been the impact, of treatment on quality of life? You strike me as a very active, fit guy. So has there been any limitations in what you can do now, or just a bit about that in terms of survivorship and physical activity now post-treatment?
Yeah, even going through my treatments, as I mentioned earlier, I just never felt like I could really just kind of sit around. I needed to be doing something because I know I always feel better anyway. I may not like running, and I really don't. But I know how it makes me feel. And I know how it improves the way that I feel when I do it. And when I don't do those kinds of things, I know that I feel more susceptible to being sick, and I feel more run down. So even through my chemo treatments, like I said, even with that Mesna bag strapped on my back, I would still go walk in the evenings. When I was in the hospital with that PICC line stuck in there with my chemo, I'd still just walk up and down the hallways so that I could just not have to sit there. And so after my surgeries and after being released, I had to start pretty slow. And so I was walking and still do walk every single day just to be able to make sure that even with the additional steps I get just doing my job, I try to just make sure that I'm up and around and getting active. And so in doing more and more as I could, it really took me about a year before I felt really comfortable to be more aggressive with my working out. And so after about a year post because really more concerned about surgery, that's really what I was more about than necessarily about the chemo and how I felt with that. And so I would go out and start jogging. That's when I started jogging again and not walking. That's when eventually I started playing tennis again, and doing those kinds of things. And so now I'm really kind of, and it took a while again, because just doing little things. I know as a coach that I know, and I've done strength training, like I said, my whole life. So I know I just can't jump kind of right back into things. But now I'm back. I lift 3 days a week. I run 3 days a week. I walk every day just to make sure, again, I'm getting a little bit of just keeping movements in. So I do get more tired than what I used to. I still, even at this point, haven't like really hard pushed myself. I mean, I've run some sprints and those kind of things, but I don't really, it's more, again, I'm not trying to be an Olympic athlete anymore. I'm just trying to make sure that I can be a healthy adult. So I just need to make sure that I can stay active and continue to move. And so that I can feel like, for me at least, that I can stay healthy. So those are outlets and avenues for me. If I feel like I'm not getting some adrenaline going in my body, that it just feels like all the chemicals and things that I've done and the treatments I go through, that I need to make sure that I'm just kind of actively moving those things and continuing to do that kind of stuff. So there's not really a limitation of so far as what I can do. Now, that being a footballer or a soccer player, I know that I'm not going out there. Probably my days of heading balls and probably taking one off the chest are probably done. But I try to get out and be as active as I can to make sure that I can do this stuff. So because I'm a high school coach now, so I'm out on the courts doing stuff every day, and so I'm being actively involved. So from that perspective, that's just part of what I do. It's to make me kind of feel whole as a person. So the physical aspect of that for me, like I said, and I would encourage people, regardless, because for me, like I said, it's just kind of a stress reliever. If you're just going to sit around in your house, I feel like that things are just going to pile on you as a result of that. And so anybody that's going through any of this stuff in whatever regards, I would encourage them to make sure that they're being as active as they can, or feel that they're comfortable with being, because like I said, I think it just puts you in a better mental state than just sitting around.
David, thank you so much. I'm cognizant of the time, so we might move back in, but thank you so much for joining us today, sharing your story. I think the audience will all agree that you are truly inspirational, and this information I've no doubt will help many patients in the future. So thank you for that.
Oh, you're very welcome, Jeff. I'm really was glad to be here. And so thank you for the time.